we would like to go to the last talk of this session, which is on the post-LASIK refractive errors and enhancement techniques. Dr. Himanshu Matalia doesn't need any introduction. He is doing some of the phenomenal work in Narayantralia, and of course, his talk on enhancement is always extremely full of pearls. I'm sure you're going to learn a lot from him. Over to you, Dr. Himanshu. Thank you.
Thank you, Vardman. I'm going to talk to you very basic talk. Starting with an example, one new LASIK surgeon, one of the glaucoma persons went out for the practice and gives me a panic call that I've done a myopic LASIK for a regular patient, and now post-operatively patient is -1 sphere in right eye and 0.75 in left eye. When do I do enhancement? Well, what I did? Well, I did nothing. I actually did cycloplegic refraction. Right eye was 0.25. Left eye was emmetropia. I reassured and sent the patient back. What we were dealing with spasm of accommodation. Well, so we should know that there are 6 major causes of post-LASIK refractive error, namely deliberate or non-deliberate undercorrection, spasm of accommodation, progression of myopia, long-term regression, cataract, and post-LASIK ectasia. I've kept the decentered ablation aside because it's totally different ballgame. Starting with deliberate or non-deliberate undercorrection. Well, before we go to that, there are certain investigations which are mandatory when you're looking at post-LASIK refractive error. One is unaided vision, cycloplegic refraction, which is absolutely must, a good slit lamp examination, corneal topography, axial length, and anterior segment OCT. So coming to, again, deliberate or non-deliberate undercorrection, typically the presentation is immediate. First post-op day, the vision will be poor. Now, if you do not have the surgical data with yourself, if you have, it's your own patient, go back and check whether there was a mistake in entry or anything like that. If you do not have data, well, you can ask patient, how was the vision on day 1? And many times patient may say that, well, vision was not so great. How do you manage? First, do a good cycloplegic refraction to confirm the refractive error. Second, if it was a deliberate undercorrection, do not jump over with the treatment. Find out the cause of deliberate undercorrection and then only go for that. Do an ASOCT, calculate the bed, calculate flap. Think about it. If it is safe for the patient, you surely can, as previous speaker said, you surely can go ahead with PRK and you should be fine. Second cause, spasm of accommodation. Typically, the presentation can be from days to months. Typically, the good vision on day 1 is norm. Usually they do not have such kind of spasm immediately on day 1. Later on, when they start work, later on the computer work, reading and all those kind of things can possibly lead to these spasms. Near vision usually is good because of pseudomyopia. They are usually type A personality. How do we treat them? Well, reassure the patient, reduce the screen time, do a cycloplegic refraction, and if it still doesn't break the cyclospasm, you may have to atropinize these patients, and usually they do well. Third is progression of myopia. We all know this is the commonest side effect of myopia, which progression. Now, typically it presents from months to years. Good vision day 1 month, and all these documentation are required and depends upon natural growth. It would stop progressing. But the most important part here is your pre-op investigation. If you included axial length measurement, well, you can claim that there was a progression of myopia. If you do not have this thing, unfortunately, you have to take a blame and call it something like long-term regression. Many times, long-term regression, which presents from months to years, has good vision on day 1 month, very slow progression, and it's diagnosed on topography where the curvature bounces back or regresses. Practically speaking, I strongly believe it does not exist. I'll give you the reason. It's highly misused terminology when you have not documented pre-op axial length, and when you do not document progression of myopia, you end up calling everything as a regression, which is actually not true. By regression, we should be documenting change in keratometric values, and which is air-tear interface. Please do not confuse it with myopic progression. Now, George Aliev's group has published a long-term data, more than 15 years of follow-up from -6 to -18. I don't know how they did -18, but interestingly, what they found was the change in K value in 15 years was not a diopter also, so which translates to 0.06 diopter K value difference in a year, which is actually not true. Now, interestingly, Dan Reinstein's group, well, again, we like to call that it's basically epithelial hypertrophy which leads to regression. Now, Dan and Reinstein's group has worked on, in fact, we also done our studies, but some other day we can talk about that. What Dan Reinstein told us that, well, change in the epithelium usually occurs first 3 months, and later on it becomes stable, and which remains stable for pretty long time. And we know that myopic regression is not 3 months. We usually call it much longer. Again, similarly, there are other papers which showed that even long-term, irrespective of moderate, low, high myopia, irrespective whether it's PRK or LASIK, the change in K value is hardly much. So K value remains stable. Hence, if we have not documented all such kind of thing, we love to take blame. And then we have to say sorry, just because we did not document the axial length measurement preoperatively, and hence we have to cut a sorry figure. So all we need to do is do a proper pre-op workup. Now, cataract, fifth cause, which usually is much later. We know that it directly reflects into poor quality of vision. There is no change in axial length, there is no change in topography, and it can be documented by a good slit lamp examination, or even some of the aberrometers can actually document the presence of cataract. The last but not least, something which we all dread of, which is post-LASIK ectasia, usually presents many years or many months later on, typically asymmetric presentation, more in one eye than other eye. That's important to document your day one vision, 1 month topography, later on topography, to claim that you did not have these things pre-existing. It's usually compound myopic astigmatism, and the best corrected vision is usually less. Your elevation-based topographer shows posterior elevation, and that's very important sign of post-LASIK ectasia. Whenever your posterior surface starts showing elevation, well, you are dealing with ectasia and nothing but ectasia. Treatment-wise, they all need immediate cross-linking. The visual rehabilitation can be done by using intracorneal ring implants, or you can do topo-guided PRK. Overall, with all these things, we still have to remember there are 6 causes of post-LASIK refractive error: deliberate or non-deliberate undercorrection, spasm of accommodation, progression of myopia, long-term regression, which is debatable, cataract, and post-LASIK ectasia. Thank you very much.